Well, welcome back to this special episode of the Dental Guys podcast at the Academy of Osseointegration 2024 meeting. I'm Wes, the Dental Guy.
And I'm John, the Dental Guy, and we have been bringing it to you. As you know, if you've been watching this, if you've been seeing some of the people we've interviewed, we've learned a lot, we've been challenged, and certainly we have pushed beyond the boundaries, just as the meeting title suggests. So we want to continue doing that, Wes, because we've had a lot of discussion through our interviews so far about consensus and how important that is, and how organizations working together to create consensus is the way to clarify the path forward. And I think that's something that has become very important over the years.
John, what it boils down to is where you're at in private practice today. You've started to either incorporate implants as a new grad, either you're a restoring dentist, maybe you're a surgeon working with restoring partners, and maybe you're a little more seasoned, like John and myself. You know, we're not that old, but we're beginning to see the results, 20-year follow-ups, 5, 10, 15, and 20. And what we've said, John, is we've said it's not really your dentistry at a year. It's your dentistry at 5, 10, and 15 that we really want to pay attention to. And as our patients are keeping teeth longer, one, our patients are also keeping their implants because they're living longer.
Right.
They're really outliving what we may have thought we intended the restoration maybe even to last, or the implant to last. And what we're seeing is the effects of that. And how do we take care of the patient?
Right.
How do we help the patient understand before they even start surgery?
That's right. And as Chandra Wadhwani said earlier, you know, the dental implant might be the most sophisticated biomedical device there is, because it is exposed to the environment.
Well, it makes us feel better about ourselves.
That's right. That's
Yeah.
right. But we have two folks with us now that we're going to bring into the show that are probably need no introduction for most of you if you've been around the implant world. First, Dr. Paul Rosen and Dr. Hom-Lay Wang. So thank you for being with us today.
Thank you for having us.
Yeah, we're excited to talk to you, and I think, you know, this meeting so far has been excellent. We've seen a lot of excellent presentations. Even, you know, Craig Mish, who we just finished talking to, said, hey, I learned a couple of things about peri-implantitis just this morning that I'm going to take back to my practice and I'm going to implement. And I think that, you know, as we go to these meetings, one of the reasons we come among many is for the ability to interact with other people and learn from each other. And talk a little bit about what you guys have been doing together, different groups, different ideas, different thought processes. How have you been working together to create consensus and bring that back to our profession?
So actually, this is the idea we had back in one of our AO Board of Director meetings, and we talk about how do we tackle this kind of emerging problems we have, which dealing with the peri-implantitis. And we certainly wanted to deal with that through the prevention, then the treatment. But how can we just do it by ourselves? We thinking about it to collaborate with the Academy of the Periodontology, and that's why we approached them, and we came up with the agreement, and that's what the consensus is coming out by bringing the expert from the two different specialty organizations. And we come down and we develop the theme. And basically, as what I said before, is one is focused on understanding how do we understand the patient's risk factors and systemic conditions. And then we will deal with the treatment, either from the mucositis to the peri-implantitis, surgical or non-surgical. So with Dr. Paul Rosen as part of the representative from the AAP side and representative from the AO side. And so we put together a very a nice group of the people who can put this down in a nice manner, and we work together to develop this consensus.
So now, when you're developing a consensus behind closed doors, does it get heated? Does it get heated? I want to know, did we have any significant disagreements that were heated? That's always interesting to me, because it's a lot of opinionated folks, right?
So that's a really good question. And to bring you back a step to the prior, when I first was approached, Hom-Lay brought this up with a task group that was looking at what could we do towards peri-implant concerns. And at first I was a bit reticent about this effort. I had my questions in my own mind. But then I thought about the broader scope of this. This is a very unique opportunity. And the reason is not just that this is the American Academy of Perio and the Academy of Osseointegration, but this brings into the equation surgeons, periodontists, restorative dentists, prosthodontists, all collaborating together to try to better the care of our patients. So your question is a good one. We have a lot of egos that are potentially involved in this, not excluding those at the podium here with you today. We have our own egos too. But I think that I've gotten a real strong sense, and Hom-Lay would probably agree with this, that we're all out and interested for the patient and the clinicians to provide the best possible care. And as you mentioned before, when we first developed implants, these were for quote-unquote dental crippled patients, and we didn't expect the longevity to the patients or to the implants to have to be 20. I mean, I'm 35 years out from my training. I see patients back that I treated 35 years ago. Not in my wildest dreams did I think about these for 35 years. And so now we're faced with things that we never anticipated earlier on. And here we are today in 2024 trying to ascertain what can we do to help this group of people. What have we learned through the years? What is our risks and what are our directions moving forward? So I think it's been a great collaborative effort. That's not to say we don't hit bumps in the road, but I think everyone's pulling together, and I know we're excited about this.
Yeah, so when you come together to come up with a consensus statement, kind of explain really what that means. What is that going to give us here when this is released? As a clinician, I'm going to read that, and how is that helping me?
So this actually has two components. The first one is we're going to have the expert in each group writing the small subjects based on the evidence. So we have the 4 papers in the group 1, which is the risk factors, and the group 2 means the treatment approach, and that's including the decontamination and the surgical, non-surgical treatment. So you have a totally 8 systematic review paper and the meta-analysis based on the evidence. And we actually break some different aspects compared to other organizations. We actually find the new information and exciting information. So first, this like 8 papers, and we're going to send it for the journal to be reviewed, and this peer review has nothing to do with us. So that will be in the Journal of Periodontology and the International Journal of Oral Maxillofacial Implants, which is both AO and AAP official journals. Then after review, we have these 8 papers, and we're going to write together with a summary paper to talk about all these findings. But that's not a consensus yet. So this is only information disseminated to the people who are participate in the consensus. Then we have the subgroup co-chairs. We sit down and figure out what the decision and recommendation guidelines. And they come up with a flow chart so that people, like every dentist, can go home and grab the flow chart and read it. Say, if I have a list, this is what I do. And this is a couple methods or technique available for me to choose. So that's a guideline. However, based on the consensus discussion and voting, we will have this either agree based upon the fact, the evidence support and the majority of expert support. Then we can also report some of the minority opinion, which is equally being respected. Then that will be published in the 2 other journals, which is International Journal and Periodontics and Restorative Dentistry, the official journal of AO, and the Clinical Advance in Periodontics, official journal of the AAP. Then every one of us can get access to this journal online and social media. So that's, you can actually get, and very easy to read.
The vetting that goes into that, it sounds deep, and I love that because we're not just receiving expert opinion, it's expert opinion, plus we're going and looking at literature. On top of that, we're sending it out to the organization's third party, per se, making sure that what's being said in these papers is correct, and then coming back and then voting upon it with those experts in this consensus meeting. I mean, that's pretty powerful, and that's really never been done before.
Yeah,
yes,
in this area.
In some respects it has, and in others it hasn't. So this collaboration, this consensus conference is much like others. We're grounded in science to begin with. These 8 papers are all based on high scientific level. That said, we are not supplying all the answers based on that. There are certain gap areas. So we're trying to have decision-making trees that come out of this based on scientific evidence. But we're also trying to fill in those gaps of areas that are not necessarily covered in the conference that are important to learn from our deliberations, and that is going to take some expert opinion as well. So that's where we differ from other groups. Other groups have strictly a scientific bent to this. Yes, we are, but we're also trying to have a deliverable. It's important to judge the science and to find out where we are. But as important, our constituent memberships rely upon what are we giving to them to move forward in their day in, day out practice for their patients. And I think this is what's a standalone for us because we're doing it both on a scientific and an expert opinion level.
It's not just grading the evidence.
Sure.
Because that's
Exactly.
we see a lot of that where it's this is evidence grade A, evidence grade B, whatever we call it. And that's very good. That's a good step. But to be able to have a document that is put together that again could apply, because we know this applies to literally every dentist that's treating implant patients is going to be able to benefit from this. But I think about this area of literature, seems quite daunting. There are some areas it seems that we have a lot of answers. But over the years, this particular topic has been debated and it has been thrown around from so many angles, and everybody seemed to have sort of their special sauce of treatment. And the kitchen sink approach, I think, as Dr. Kumar said yesterday, And so speak to that a little bit, the challenges of inclusion and exclusion criteria, for instance. I mean, the number of articles reviewed. I mean, do you have idea of the numbers we're talking about here?
Was it all 770 that you've been involved in?
No, actually,
that's not fair. It's far more than 770.
I was trying to downplay it a little bit.
So, Wes, I think it's interesting you asking that question. I think. For example, one of the consensus paper systematic review paper we're trying to write, the authors actually went through 4,000 papers. And they come down with about 150 or some things. And then they look at and maybe extract the data from 90 papers. That's a lot.
That's a lot.
And then come out from all this evidence, they come down with some of the consensus or the at least findings. So that's based on the science. And as Paul said very nicely, there are gray areas which people don't have the evidence. So we also recognize, so we're reading that, and that way we can actually discuss about it, and then we can rely on the expert opinion and figure out how to deal with it.
And two, I think this is going to impact, like Dr. Kumar, I think she's excited to hear some of these gray areas so she can maybe go back and in university settings or, study these things that we don't really have all the answers for yet. But even then, we're going to take expert opinion and the best knowledge we have and still give us a document to go forward. As we move forward, you mentioned this. These organizations that we're belonging to, the AAP, the Academy of Osseointegration, I think as they get more involved going forward, not that they haven't been in the past, but in a new way to help clinicians really be able to boil down and on Monday morning deliver great care. They're asking for that, and even more now, they're asking for direction and creating value for these organizations. I think is important going forward. We want the Academy to grow. John and I were really positively affected by the report that the Academy is growing and reaching across seas and inviting international participants. I wonder, where do you see it going from here? This is a big consensus agreement, and it's a group of people. Do we see more of this coming from our organization?
Well, I certainly think so. I think Hom-Lay would agree that this has far-reaching benefits. It benefits, yes, us as periodontists and as oral surgeons, prosthodontists, and restorative dentists. But think about this. We are being sponsored in this endeavor by corporate. Corporate can take these findings because this is a unique opportunity here. We are having a review of both the surgical component issues and the restorative component issues. So in the futuristic design of implants and devices to help clean these areas, etc., corporate involvement can look at these documents and say, okay, there's evidence for these factors that prevent peri-implantitis in the restorative end. Maybe we need to guide our efforts in future product developments towards these. And these are things that aren't necessarily thought out in prior endeavors. They just look at, this is the science, this is where we are, we've got to avoid the problem. Well, what can we do futuristically speaking? And most conferences that I'm aware of have really looked only at the surgical end or the biologic aspect of this and not taken a more holistic view. So we're hopeful that such entities as the American Dental Association may take a look at this, maybe FDI, other entities that could benefit from this, and also the corporate world of implantology, and also those who provide hygiene for our patients, because there's a lot of people out there being restored with an implant for their problems, and we need to meet the needs for all of these people.
Yeah. Let's talk about the industry repercussions. I think it's a great place to talk a little bit because, we've had several guests on the last couple of days that have talked about, because of the way that, for instance, implant designs are often put out there, it is a like-in-kind device. And so it's there's been more of sort of, well, we have to see how it goes approach, with this new design that comes out. Speak to how, I feel like we need to be holding industry accountable in a positive way toward what can we do with our design so it's not a reactive approach, but it's a proactive approach. How has this been received by industry partners and corporate partners as to how they're seeing this could influence their research, their designs going forward?
Great questions, John. I think I can give you some of the discussion we had with corporate sponsors. For example, one of the sponsors actually said, by participating in this consensus conference and reading this document, I can figure out if my company can develop this product or improve these devices to avoid some of the problem you may foresee coming. Or if I have this type of problem, what kind of a product can I develop to overcome and to treat these issues? So it actually guided them to save a lot of the unnecessary research fund. One person actually said they sunset their research grant because they don't think it's going to help. And so I think by using this consensus conference data or the outcomes, we can streamline some of their ideas, and they can also help us out as a clinician to develop a better, higher quality of product so we can minimize this type of issues. And if we unfortunately encounter some of these concerns, we have the tools, we have the technology and material to treat it and to get a successful outcome. So I think it's a win-win situation, and we see the corporate is very pleased and happy to see this type of outcome.
Yeah, if I'm the industry partner, I'm thinking this gives me a guideline by which I can sort of say, hey, if I followed the rules, if you will, that were sort of set by these guidelines, I'm doing best practices. And now there's other factors. There's other training factors and clinician factors and things that are outside of the industry control, but they need guidelines to work with. And it sounds like that I would think they would be very positive toward that.
I think they understand that this conference is one of collaboration. We're trying to look at all the players involved and the stakes that are involved with this, and we're trying to help out in our management and treatment and in their development of products and care. So I'm hopeful that everyone feels like this is a win-win scenario at the end of the day, and something that is forward-thinking. That's the key, is not only does it address the problems today, but how does it prognosticate and address potential problems and fend them off as preventive measures.
We've done a great job in dentistry of compartmentalizing our specialties. Well, you guys do over here. You're the periodontist, and you're the prosthodontist, and you're the general dentist, and you're the oral surgeons. And we didn't do a great job of communicating. And it's organizations like the Academy of Osseointegration and the AAP and other people that are starting to really come together more and recognize. And even our keynote speaker, Dr. Edward Schwartz, coming across from the medical research field and applying the knowledge that medicine has. So we're talking across even industry lines, and talking to Dr. Michael Norton yesterday about what's going on in orthopedics and some of the research we saw from Michael Pico's come out in a most recent journal from JOMI. I think it's exciting to hear about what can be done when we all come together. And that's the social network of really the Academy of Osseointegration at its best.
Yeah, I'm interested though in the gray areas a little bit, right? So I
love that about you.
Yeah, I just am.
In your gray suit today.
That's right. It fits perfectly. So, what are the things that we maybe know the least about? As you've been reviewing a lot of this, and we've heard a lot of presentations discussing some of these, the multifactorial. That's a word I feel like we've heard that word 10,000 times in the last day. Multifactorial. But what are the things that that we might have the most need to rely on expert opinion to make decisions? Where would we be looking?
One of the most highlight area is occlusion. I think we cannot conduct the research to look in occlusion because you cannot put a patient in a harmful way. So there's no data. It's always limited data. You can only do an animal, but it's not human. So there are different chewing style, musculoskeletal functions. So I think that's the gray area. So it's going to rely on the people, like all the experts out there and in the daily basis, treating this type of patient and seeing the outcomes. So I think that's one area we look at as a huge gray area. The other area is we know the hygiene, it matters, but some people say, hygiene may not be important in terms if you have a additional phenotype to protect. So we don't have the data. Again, you don't put the patient in a harmful ways and you don't brush your teeth and for certain days, and we're going to see what's outcome. So again, that's the area I think in the future we probably need to be more explosive in this area and to understand how the occlusion play a role in our implant reconstruction.
The hopeful point as well is the gray areas are somewhat the known unknowns. The big question are the unknown unknowns at this point. The gray areas that we don't even realize that are gray areas, and maybe through our collaborative efforts, we might identify some of those, things that we didn't think about before this conference. And I'm hopeful maybe we'll unearth a couple of things that are unknown unknowns to us now that might become at least known unknowns and areas that we need to pursue.
Yeah, there was one thing that Dr. Schwartz mentioned about a known that wasn't doing a thing. And that was the antibiotic beads that orthopedic surgeons are placing, and they all raise their hands as they know that it doesn't work, but yet they still use it.
And we have things like that in our world.
We have things like that in our world, and I think from consensus like this, we might be able to get that.
Yeah, I think that's exactly what I was trying to refer to, and then you beat me in one step earlier. So basically, another area is a gene, DNA. How the patient's gene or DNA play a role in the initiation of peri-implantitis. We know some patient, no matter how you do, they're going to get peri-implantitis or bone loss. But some other patient, no matter what you let it happen, it just didn't have a bone loss.
Yeah.
So we don't understand that at all. And I think from Dr. Schwartz's presentation, we see that. They're starting to identify certain gene and play a role in the way you got a disease or osteomyelitis, or you got an infection, or you don't. So that may happen in the future. So that's the unknown and unknown.
Well, I like what he said about occlusion, John, because that's a controversial thing that we've put in our lectures for years. And,
that's right.
Tom Taylor, University of Connecticut, a guy after our own heart, interviewed by us years ago at AAP, talking about occlusion and some of the tests that were done there. We need to do more things in that realm.
It's interesting how many things that, over all these years that we get very dogmatic positions on, and occlusion's always been, I think, one of those that largely is we haven't moved that far from the old Hanau Quint, of just Egyptian, hieroglyphics almost, of trying to understand, so yes, it's good to identify the things we don't know. And I think that's an important place to be. So, tell me where we are in this process. Where are we now, and what is the timeline for where we might go to get there?
Well, we're pretty excited in that we've met the deadline and goal of having all the papers submitted for review. We've already gotten one of those 8 papers back, And it had minor modifications, and that's due to a great group effort by all the co-chairs here and the section leaders as well, reviewing these papers and making sure they're up to speed. So our next step is hopefully getting them through review and to final submission form. We're in the process of coming up with decision trees at this point in time. Our section leaders have already addressed that and have given basic templates to both Hom-Lay and myself. So we're well along the way there. We're hoping from these papers we will identify those gray areas. We're meeting with the editors for IJOMI and CAP and IJPRD and CAP, and coming up with some of the gray area papers that are going to need to be addressing some of these areas as well, along with the decision trees and moving forward. So April 15th was a big deadline date again. Besides tax time, we are taxing our reviewers to get things done on a timely basis, because we need to get these papers out to all of the participants in this conference to review and be familiar with. Because when we come out to Chicago August 14th, we have to hit the ground running. We only have a day, 2 days really, to get through all this and come to a final consensus. So that is where we're at. I think I pretty much hit all the major highlights at this point. But we're in a good place. It's taken a very heavy, a very collaborative lift, but we're in a good spot.
Well, this has been amazing, and I really appreciate what the Academy and the AAP is doing here in this collaboration. Thank you so much, Paul. Thank you, Hom-Lay, for coming on to the show to talk about these things. We look forward to more from the Academy of Osseointegration, so thank you so much.
Thank you very much.
Wes and John, thank you very much for this opportunity to share our excitement and where we're at.
Yeah, absolutely. Well, if you've been listening to this, and of course we've continued to try to bring you from the highest levels, the information that's the most current, where are we going, where are we now, and it sounds like we're very close to this very exciting development in our world that may really reach maybe everyone in the profession. So it's really cool to get to talk to the folks who are right in the thick of that. So once again, thanks to Dr. Rosen, Dr. Wang. For Wes, I'm John. We are the Dental Guys.